I come from not only Switzerland, as I was presented. I did a great part of my career in Lausanne. And Lausanne is one of the large centers for the treatment of uveal melanoma in Europe. We have proton beams, and we have patients from Greece, Spain, Italy, France, and so on. And I moved to Berlin 3 years ago, and now I'm mainly in Berlin, still working in Lausanne in the field of uveal melanoma, doing some kind of research. But in Berlin, it's also one of the largest centers in Europe. There are 2 or 3 in Germany. They also have the technique of the proton beam. So patients from a great part of Germany are coming to Berlin and from outside. What I would like to say is so that I worked in that field for 20, 25 years. As a medical oncologist, it's sort of a niche, it's sort of a hobby, because our life is mainly for treating the frequent cancer and not really these very often diseases. Anyhow, I was interested because of the fact that Lausanne was a major center for this type of disease. I was interested for such a long time, and I've seen the evolution. At the beginning, we were very few doctors taking care of this patient as medical oncologists. Of course, the ophthalmologists were doing it perfectly, but for us, we were very few interested in treating this patient. And in the recent year, there was an explosion in our knowledge of the biology, of the way to treat the patient, of the natural history, and so on and so forth. You have seen already part of it, and it has changed the field, and it gives a lot of hope. I'm not going to give you sort of miraculous results, but I will show you where the fields go now, at least in part. We have already heard part of it with local therapy. What I would like to also to emphasize, I think it's for me as a doctor, as a scientist, very difficult to speak about median progression-free survival, median survival. What does it mean for an individual? For me, it does mean nothing. You can see this curve. These curves are useful for us to compare treatment, to sort of promote a new treatment. If you look at a patient you think that his prognosis is bad, you will follow him differently. But what will be the future of one person, especially, we don't know. So I would sort of tell you, be careful not to take these numbers for you. They are really the numbers for scientists and for doctors to sort of lead the treatment. If you try to put you on the curve that you see, you can put, if you're optimistic, you put you on the right part, and if you're pessimistic, on the left part. So be careful with that. In my practice, I never give numbers. I never give a median progression-free survival to any of my patients because I don't know. And it's a fact, I don't know. So part of it, what I will show you, you have already heard a little bit about it. So here I come back to the prognosis of the patient. So when we see a patient, when the ophthalmologist sees the patient, he will look at the size, and the bigger the size, the worse the prognosis. And you see these curves. I will not go into numbers, but you see that the curves are lower down. When they go down, it's not as good as when they are up. But so when you have a very small tumor, you are doing better. When you have an extension outside the globe, you are doing worse, as well as when you get an extension in the ciliary body. So you have these factors that are clinical factors that the doctor, the ophthalmologist is looking at, and at the end you have a sort of staging. And this staging gives you the patients that are doing good and the patients that are doing bad. The point that is important here for me is to know how to improve at least the patients who are doing bad. So somebody in the audience asked for a treatment that can be given after the local treatment, after the surgery or after the radiation therapy. And we have to consider who are these patients so we can select them clinically I would say in Switzerland, it's what we do. In the majority of Europe, it's what we do. But as you have heard from the first speaker, now we are also keen to have more precise indication. Let's say if you look at this group of patients that are stage 1, so doing very well, you still have a couple of patients that are doing worse in this population that have been clinically detected as good. And with the genetics, with the biology, all what you have heard, so looking at the chromosomal abnormalities or the gene expression signature, it's possible to know the patient that is doing good or bad. And it's important. Is it important to know? I should ask you the question, is it important for you to know? For us, it's important because we think that if we know how the patient is doing bad, maybe we can follow him differently. Or if we have a treatment that will be with some efficacy, we can give it very early on, we call it adjuvant, and maybe improve the prognosis. It can be important, it seems, for the patient also maybe to know, to have sort of a view if he has at risk of recurring, to manage his life like broadly in a way or in the other. But this is very individual patients. Some patients, they want to know, some they don't want to know. So you have this. What I can say also is that there are not so many centers that are doing biopsy. In the UK, Liverpool was really a pioneer in that field. Some other centers, as you have heard, in Europe are doing it, but a majority of people, of ophthalmologists in Europe, they don't do biopsy. And the opposite in the US, almost all the centers are doing biopsy now. Even if it has not a direct impact right now, it will have, we hope. So then with time, a certain number of patients will develop metastatic disease. And as you know, the liver is in the majority of the cases the first site of metastasis. And half of the patient will have only liver metastasis at the time of diagnosis, visible at time of diagnosis. But if you look at this table, you can see that with time, and if you look with the appropriate exam, you do a PET scan, you do a bone scan, and so on and so forth, you can find patients that think have only liver, but they have disease elsewhere. So I don't think we have to consider, and one person asked that question before, that it's sort of localized disease in the liver. It's a disseminated disease that starts in the liver but goes elsewhere also. There are patients that has never liver metastasis. It occurs after 3 years and it's infrequent at diagnosis. And now when we look at the liver, and also to follow the previous speaker, it's not all liver metastases are the same. You can have one very, very large liver metastasis in taking all the right lobe of the liver. So here you have the liver, the spleen, the vertebral bodies, the stomach. So you have here the liver. But if you do it properly with the proper surgery, you can maybe remove that, even if it's huge, and have a patient that has no disease anymore. And sometimes you have only 2 or 3 lesions that can also be removed by surgery or other local therapy. Of course, in 70% of the patients, there are more than one, more than 2 or 3 or 4. And as said, very often, when you open the patient, you look how with the liver, you see that there are one big one here, but a lot of very, very small, like we call it, miliary disease. So the approach for this type of disease is very different, depending how it looks like. And when the disease is there, Here again, I'm sorry to speak about median survival, median, and so on and so forth, but just to make you see that there are patients that survive quite like I had 5 years. It's a small proportion, but they are still alive, even that they're metastatic disease. But as a median, it's about a year. And if you break down the patient with different site of metastases, different size and so on, the size of the metastases, what we call the performance status, the status of the patient, or some liver function test, you can sort of divide the patient with metastatic disease in 3, the very bad, the ones that are doing badly very quickly, and the ones that are doing better, like 18 months median survival, and at 3 or 4 years, you see 20% are alive. This was one study that is now probably just this year was published, and in another study that was just not published but was presented this year at the American Society of Clinical Oncology. It's another large study with a lot of patients, like almost 1,000 patients that have been collected all over the world, and we can see also the same thing. Now, what is the therapy for metastatic disease? So, I would like to say there are really no standard. There were standards when we knew nothing, and we thought, okay, let's give chemotherapy, like for skin melanoma. But I would sort of tell you in your head, you don't have to think there are standards. So it will help you maybe to participate to clinical trials and to help the field to improve, and in the future other patients to have better therapies. But of course, for every person that we see, we try to find a therapy that will help him in his condition. And what do we have? We spoke about this local regional treatment, and we have this systemic therapy, so general therapy. Locally, surgery, from my opinion, remains a very good option when it can be given. TACE is embolization with chemo. You can do embolization of the artery in the liver with immunotherapy, done in the US mainly. You can do radioembolization, so CIRT. You put radiation therapy. The principle is exactly the same. You block the artery, you give something that stays in the liver and will kill the tumor. You can give chemotherapy directly into the liver, but without embolization. You can do what we have heard just now, isolated hepatic perfusion, or in the past, isolated was in the past, percutaneous is now. And the systemic therapy, we are left sometimes with the help of chemotherapy. I will speak a bit about targeted therapies or focus therapy on the target that we have discovered by biological exam. And we all speak about immunotherapy. You all know about immunotherapy. We have a great hope in immunotherapy because we have seen fantastic results this 4-5 years for skin melanoma, but lung cancer, renal cancer, you name it, immunotherapy might have some effect or sometimes cure the patient, like for skin melanoma. So where are we in all this therapy? So surgery. You see, again, I go for the median survival, so we have the same language, but you can see if the median survival is about a year, a bit less than a year, when you do, you cannot operate, it's 27 months, so it's sort of twice as good when you can do surgery. And these are the Liverpool experience, recently published, an old experience from the Curie Institute from Paris. The results are exactly the same. The question that, are we selecting patients that are able to go through that? Or are the patients that have the bad prognosis, the one I've shown you here, this one here with the red or green, how can we salvage that? And you see that the green patient, there was only 1 or 2 in this trial, but in this review, sorry. But you can see that even the ones that are intermediate risk are also doing good with surgery, meaning that we think that still surgery, if we can do it, is really a very good option. And it leads also to one of the questions, how do we have to follow the patient that are high risk? Do we have to do sonogram every 6 months, MRI, CT scan? How do we have to follow this patient at risk if we know that maybe with surgery we can sort of salvage early this patient? So I will come back to this local treatment. I cannot go through all the local treatment, the radiation therapy, immunotherapy, and so on and so forth that are given locally. Here is the percutaneous hepatic perfusion that we have heard. And here is the study that I have run with the EORTC, so the European Group of Cancer Research. They are the only 2 randomized trials. What does it mean? That we had a part of the patient that received the new treatment, so the hepatic perfusion or the infusion with chemotherapy, or the standard treatment. And it's summarized here. Of course, in that trial, a lot of the patients that received the treatment were crossed over. So when they progressed on the standard treatment, they received the experimental treatment. Here in that study, we didn't allow the crossover, so they were not allowed to receive the intraarterial chemotherapy, but a lot of this patient went to get other embolization in the course of the disease and progression. And we have heard about it, so it's a lot of efficacy. You have partial response and stable disease in the range of 88% here, and here 50% almost with this, and sort of an increase in the progression-free survival, so a real biological impact. But when we look at survival for whatever reason, crossover, no crossover, there are a lot of discussion around why this trial was not positive. Our trial that had not so much crossover was not positive either for overall survival. We still can think that if we think that, as said by one of you, that it's a systemic disease, that there are metastases elsewhere, it means that we treat for quite a while the liver, we postpone the progression, but at the end the disease will grow elsewhere, and there is really a concept to put a systemic treatment and a local treatment together that should be studied. And in that field, I can mention this study that we are doing in Berlin. We compare 2 types of local treatment. So not 3, that would be nice to have the Delcat in the line, but a TACE treatment, so with chemotherapy or with radiation therapy in non-pre-treated patients. And in Lausanne, I have started this treatment where we do a local therapy with a radiation that is given locally, so the 3rd treatment, with systemic treatment. I don't go into the details of the study that is trying to see how we can give this treatment without too much toxicity. It's why we call it a phase 1 study. We looked really at the toxicity, also at the efficacy. So, but here it's a targeted therapy, sorafenib, what we call an anti-angiogenic agent. It kills the new vessel that feeds the tumor. So we give it before or just after, and we check what is the toxicity to try the best combination and then to study it in more patients. So another trial. The systemic chemotherapy, should we still give systemic chemotherapy? My answer is yes, because again, for what we know for a cohort of patients, let's say 50 patients or 100 patients, is never the same that what we have for one person. So when you have your patient in front of you and you want to do something, why would this patient not the one that will benefit, even if it's not so frequent? We see sometimes patients that really benefit of chemotherapy. It didn't impact so much. There is a risk of having only the toxicity and not the activity in giving a chemotherapy, but at least this should be discussed with the patient. Here it's this fotimustine, this new therapy. You see the response rate is about 2.5%, but the median overall survival is not modified. Here for another study with the TIC, no responses, but the median survival was about the same, between 9 and 12 months. So I would sort of say, for me, it's not, I try not to give chemotherapy, but sometimes you have to give chemotherapy. Now, when we started to dissect the biology of this tumor, we had a great hope to find a target that could be treated with a new medication. As said already, the point that even if the scientists can define this pathway, see where are the abnormalities in the pathway, then you have to find a drug company that will be interested to develop a drug or to test a drug that is already there for other diseases in that disease. And so it's pretty difficult, but still we know that there are overexpression of some receptor. There are this pathway that activate that tumor growth and proliferation and metastasis that are also activated by different mechanism, biological mechanism that I will not go into too much because of time. I've already. I will give you one example. A drug that block this pathway here. That called selumetinib, that you have heard because we spoke about it a lot. It made us dream that we could go for this treatment and for an adjuvant treatment in the early setting. And this from the work from Carvajal. You can see here 51% of the patient had some benefit compared to 6% in the chemotherapy arm. You see the decrease in liver metastasis. Here in the PET, you don't see it anymore, or in this local recurrence that disappeared. So there is some activity. There is an improvement in progression-free survival. With this, we had the hope, but the company said we have to repeat that we want to have a confirmation. And so we had this study that is called SUMMIT, where the treatment was chemotherapy plus selumetinib versus chemotherapy alone. And unfortunately, what was presented this year showed that the hope we had in that molecule is a bit fading, and we have to rethink how to use this molecule and with which type of drug or how to combine it. Then we thought maybe we can block these pathways of the MEK the same, but the other pathways, so there are two pathways that activate, so a double blockage with these two drugs from GSK. And unfortunately, what presented at ASCO this year didn't show any difference in progression-free survival or response rate. And as I said, we have to learn how to use this drug, and there is from Paul Nathan here in England at the Lister Hospital and also the University of Liverpool, this study that is now running here and that will be opened in Berlin soon is called the CellPAC study, where selumetinib is studied alone or in combination in a different way with a chemotherapy called paclitaxel. Now we have quite a lot of hope for the immunotherapy, so how to increase our own defense. We have this new drug that we call immune checkpoint inhibitor. We'll come back to this. We have this molecule, these two types of molecules that sort of activate the T cells, and we can also give T cells that we take from outside the body of a patient, give it back after having stimulated these T cells. I wanted to show you if I have time. So you see, these are lymphocytes. These are tumor cells in blue. And you see this lymphocyte, they are able to recognize these tumor cells as being foreign body, and they come and taste, touch, and by a way of recognition, go through the tumor and will give some poison directly to the tumor. You have another view with another color, but it's also a lymphocyte, and it goes. So we believe now that these cells are really the ones that can really cure cancer. We see that with skin melanoma. When you activate these cells, they are really, really potent because they can recognize what is foreign in our body. So you have it here again, the tumor cells and this lymphocyte. And here, if you look what's going on near these fingers, you have sort of recognition. Here are the blue, so the lymphocytes and the tumor cells, and they can sort of recognize. And usually, when the tumor recognizes the T cells or the T cell recognize the tumor, the tumor is able to block the T cells, or in the lymph nodes or at the tumor site. And now there are drugs that block this block, so release this sort of release the blockage from the T cells of the T cell by the tumor at these two levels. So they are called anti-CTLA-4, anti-PD-1. The point that the experience that is now collected and that was also presented this year with this type of drug is that it doesn't give so much of direct anti-tumor effect, and we don't have at that point the feeling that it's increasing or the progression-free survival or the survival. So it's a bit disappointing. It's so exciting in the skin melanoma, a bit disappointing for the uveal melanoma. The same thing for the other one, the anti-PD-1, where the anti-tumor effect that you see here is very limited, and the PFS also, and the overall survival also. Does it mean that it doesn't work? It might mean that we don't know exactly how to use them both together. There are studies that are trying to use these two drugs both together, but are coming also other modulation of the immune system that might make them work. So we don't have to throw them away. We have to keep them and continue to study. Another molecule is this sort of two bispecific molecule that you call IM6 GP100. GP100 is an antigen, so it's something that is recognized by the T cell that is recognized by that molecule that will bring the T cell to be activated. You see here the tumor cell, the T cell. This molecule here in brown, yellow, will do sort of a link between the tumor cells and the T cells and will activate the T cell that will be able to kill the tumor cells. There are the first patients that have been treated with this, with uveal melanoma patients. So here you have 15 patients. You see that there are two about these 15 that had a very good response and quite a lot that had a stabilization of the disease. And now there is a clinical trial that's in preparation, and in England is already available. This drug is already available in some of the centers, like in Liverpool, or I don't know exactly which other hospital, in its phase 1-2 development. But this will be a phase 2 randomized trial of this molecule against DTIC. Adoptive cell transfers, what is it? You take the T cells of the patient, you take them in the lab, you modify them genetically, and you give them back genetically so they recognize the tumor better, and you give them back to the patient. This study is now running in Amsterdam, soon in Berlin also. You have the patient to collect the T cells. You send these T cells to the lab. We work on it. We expand the number of T cells. We put a new receptor against the tumor in it. In the meantime, when all this is ready, we give the chemotherapy to make some room for these new T cells in the body of the patient, and we give them back to the patient. And the first patients that are being treated now in Amsterdam, you can see that some of these patients had some good response here in the liver or here in a mass in the thigh. This patient had skin melanoma. They not all have uveal melanoma, but there is some hope. Another line of development that we have started 6 months ago, about 8 months ago in Berlin, it's what we call precision medicine. So precision medicine, you will hear a lot about it. It's how to analyze really very, very quickly a tumor. So here you take a metastatic melanoma. So here it's a skin, but we do it with uveal melanoma patient. And you do a lot of genetic analysis, so what we call next generation sequencing, methylome. So I don't want to go into but you really go deep in the tumor. You put them in culture, you test drug on this culture, and you have to do it in a 3-4 weeks period. So at a certain point, you give an advice that may be a drug that is not a classic drug for the disease, might be have some efficacy. Here is what we have. Here is for a patient with an uveal melanoma. So we had a mutation of GNAC. You have here also mutation at F3B1. You have some amplification. So you have all this genetic analysis. You know if it's amplified, mutated, and you have drugs that might act against this modification. And we then discuss with the patient, these drugs are not accepted, they are not for this disease, but if they are available, or if we have a clinical trial, we can propose this to the patient. And we have started that, and there is now one patient with uveal melanoma that's receiving trametinib, and on this basis, and with trametinib, this patient is doing better now for a few months. So we are a bit short, but it's a way to go. There are other trials in the United States that go in that direction to try to find the drug for the tumor for the patient, a special patient. So my clinical take-home message are that clinical trial is preferred. We have always to think about it. Never forget surgery. Local intrahepatic treatment might have a great impact for the patient at a certain point. probably should be combined with systemic treatment. I don't like so much chemotherapy anymore. We have to learn about checkpoint inhibitor and some of this modulation of the immune system. There are different studies going on different targets. It doesn't mean because selumetinib didn't work as well as we thought that we have to abandon. There are other ways to go on. We are at the beginning of something. There are hope in this new bispecific molecule in cells, in genetic studies. I was asked to add 2 words for conjunctival melanoma, so I have 2 slides, so I'm finished after that. Just to say that if uveal melanoma is rare, conjunctival is very, very rare. So it's 0.5 cases the most by million population, so it's between 13 and 32 patients per year in UK. So I would say that I haven't seen really so many of these patients, and we don't know exactly how to treat them. The point that if we study the biology of the conjunctival melanoma, we see that the biology, when you look at the different genes, is exactly the same that the one of skin melanoma. And so we are tempted, even if there are not much of experience, to treat them in the same way. I don't go back to all this in green are potential drugs that can be used. And so there are no standard for conjunctival melanoma, but they should be treated as cutaneous melanoma with immunotherapy first and targeted therapy with BRAF inhibitor and MEK inhibitor. And here the experience of skin melanoma with here the immunotherapy, and you see that there is a plateau. It means that the patient here are probably cured of the metastatic skin melanoma. That is really something that was not expected 5 years ago. And there is also quite a lot of activity of this targeted therapy. And we hope that with conjunctival melanoma we'll get this type of results also. Thank you for your attention.
That was fantastic. Thank you so much, Professor. Has anybody got any questions for the Professor?
Hi. I wanted to ask, after the sort of poor results in the Summit trial, why any patient would choose to take selumetinib in any form. For instance, with the cell pack trial, why do we expect results from a single inhibitor drug?
The point is exactly what I said already. There are trials that are negative. Let's say the Summit trial is negative. Let's say I'm not sure it's completely negative because the way it was designed. But now you have a patient, and then when you look at precision medicine, you can see that in a trial, you have a number of patients, like 100 patients, that are very heterogeneous. And we can think that if we don't have the clue to know which one will respond to selumetinib, at the end, we end up with a negative trial, even though this selumetinib would have been useful or has been useful for so and so many patients that maybe with precision medicine we'll see.
You can ask, in respect of that, you talk about results that it's been effective in patients, but has it improved overall survival in any patients, and what percentage in the long term, rather than just a partial response?
So we are again in this same type of discussion. I have to rely upon studies as a scientist to advise my patient. And the studies say it doesn't increase the overall survival. So I would say, we have to discuss this. I will not increase your overall survival, but we have not seen many drugs for uveal melanoma that are increasing the overall survival. But it might improve you for a certain time, and as said before, in this time where you don't progress, it might be that there are new therapy, new trials, new way of doing things that can profit to you.
So, thank you very much for your talk. Am I right in saying then that these early immunotherapy studies on patients with uveal melanoma indicate that they're less responsive than patients with skin melanoma? And why do you think that's the case?
It's a very good question. I can answer two ways. One way is to say that we have learned now, it's really very recent, that this new immunotherapy, they sort of wake up the whole immune system, not only against the regular antigen that makes a melanoma, but against a lot what we call neoantigens. We know that melanoma, if you look at the genome of a melanoma, you will, in the genomic study, there are hundreds, thousands of mutations that are all targeted by the fact that you awake the immune system. If you look, by comparison, the number of mutations in uveal melanoma, the number are very few. And we think that there may be not so many of these neoantigens due to the mutation process. This one way. The other way, when you look under the microscope and you look at the presence of what we call PD-L1, you block PD-L1, so you look under the microscope in the tumor, in the uveal melanoma, if the PD-L1 is there. It is not. It is in cutaneous, it is not. So you block something that is not there. But there are other studies that show that you can make this PD-L1 appear in uveal melanoma. So if you stimulate, let's say, with interferon, let's say, that will appear. And then you see that the strategy would be to give something that will sort of increase the immunogenicity of the tumor, and then they give the PD-L1 inhibitor. You see, so we are in that process. I cannot say more.
Thank you very much. I mean, we're just in the very early stages of this whole genetic engineering process, really, aren't we?
So. Yeah, exactly.